Next one, you
Go ahead.
Yeah, go ahead. Yeah.
Go ahead.
Welcome back to El Paso.
Yes, we're
So
back
before
live.
I show you the second case, let me go over where we were. So you remember we had a long CTO, retrogradely we crossed, and then I did ballooning, and now you can see that I brought an anti-grade wire and did a roadmap, and I was able to cross that area. So actually the wire went easily all the way down, and then over this wire from anti-grade, Navi was pushed all the way down, and a filter, spider filter, was delivered right at the distal part of the tibial popliteal artery. I'm a strong believer in distal protection. After that, since we had a moderately soft plaque, I decided to do directional atherectomy, and I completely believe in Dr. Dippel's talk. That is a very important tool we have, atherectomy and removing the plaque rather than just hurting the artery with just cracking and ballooning and trying to, still I stay away from the stents. So important part of the directional atherectomy or any atherectomy is that you try to remove as much plaque as possible. So you change the kind of a compliance of the vessel. It's not very hard. So you can see that the whole, we had to do it like a couple of times to remove the device because it was full of plaque. So this is after doing that. You can see you have a recanalization. The proximal area, the proximal cap doesn't look really good, but this is just the directional atherectomy. You can see it's a pretty good lumen obtained. Keep going down, and you can see that all the way down. So this is a drug-coated balloon impact. I also strongly believe in drug-coated technology. So this is an impact from Medtronic. There was a lot of negative remodeling of the vessel, 4.0 vessel. So this is a 4.0 by 25 impact. So we go nominal inflations at least for 3 minutes. So after doing balloon angioplasty, this is the result. You can see still some dissection right at the proximal and ostium. I really don't like the proximal, the cap, but the rest of the vessel looks beautiful. There's no stenting here. There's no metal here, and I think it's pretty good. So I decided to, and you can see distally here, there's a great, beautiful runoff, same two vessels we had in the beginning. So I went back with 5.0 short balloon to see if I can have a local pressure and see if it can help to touch up this dissections. And this is after that, this major dissection. And the problem is, if we don't fix there, this is going to occlude right there. So I decided to put a one stent there. This is a 6.0 by 60 Everflex non-drug-coated stent, but we already delivered the drug right there. So I feel very comfortable that it should do well. So one important thing is you have to make sure I'm just giving a little bit of contrast so that it doesn't jump backward and across the profunda. After that was post-dilatation. And here you can see, now it makes the distal artery looks ugly. So I went back with the same balloon, and I just did a little dilation, low pressure dilation to this vessel. And this is the final result. Has a great runoff all the way down to the foot. Let me go to the
It's a beautiful outcome.
case, Olivia. Excuse me?
That was a beautiful outcome. Eric, any thoughts at all about the double technique you were talking about, drug-eluting stent and DCB versus just the plain bare metal?
No,
I'm curious up and down the panel, but anybody put drug in there or just the bare metal?
I don't think that we know the correct dose for these, to be honest with you. I mean, I think that we're one-time dosing these arteries and hoping they stay open for the rest of the patient's lives, and I don't know if that's the case or not with what we are currently doing. I have done double, like drug-coated balloon with drug-eluting stent. I don't think it's a problem. There's animal data that says it's safe, and for high-risk patients, I would do that. But for this, I think it's certainly acceptable to use a drug-coated balloon and then a bare metal stent. I think that's an acceptable option.
But why just put a DES and be done with it?
What's that?
We just put an ES and be done with it.
That's another option too.
I just don't like the
I
metal.
mean, I think if you ask
Yeah.
10 of us, you're going to get 12 answers.
Exactly.
So
Sure.
which
Okay.
answer do you
Yeah.
want to
I
use?
would have done exactly what he did.
That's
but
right.
Really, but there'll be some going back to the coronary world,
Yeah.
you know what I mean?
Yeah.
Yeah.
Keep going.
Keep it.
Do you have another case for
All right,
us?
Yeah,
for
he's
the
got
sake
it,
of
yeah.
time. So this is another interesting gentleman, 66-year-old. I recently saw him, I don't know, a few weeks ago. History of long-standing insulin-dependent diabetes, hypertension. And actually he came to me because he's having a non-healing wound to the right great toe and very painful left toe.
Oh,
Classic looking, and he's been sent from one primary care to another, and from there, and eventually they came to me. So had a very abnormal physical findings. He underwent an angiogram which showed that his right SFA has a short complete occlusion, and the tubules are severely diseased. So I did fix the SFA, open the AT all the way down, and actually he's almost healed. So he still has a significant discomfort on the foot on the left. So decided to come down today to do the case. So angiograms in the past had shown that he has some disease in the SFA, but his main problem is tibials. So I already took some images and I want to show you and see what you guys think. So in my practice, all the tibial vessels, I get an anti-grade access. Not only anti-grade access, I go SFA rather than common femoral because it's a major headache when you do common femoral and half of the time your void is going into profunda. I have done about 1,500 cases, proximal SFA, and I do not see any negative to it. Okay, so here you can see that it's a proximal SFA access, micropuncture, and I always pre-dial with a short 5 or 6 to create enough lumen, and then you exchange your 035 wire, and this is a 645 Terumo going. So there was kind of dampening because there's some lesions in the middle, so I have to kind of pull back, and this is the images. So you can see that in the middle portion, there's some disease needs to be definitely fixed, which I will do while coming back. Now, coming downward, you can see that you start seeing extensive collateralization, and so very hard to say what is what. I know that almost all the arteries are occluded. There's a lot of overlap of collaterals, but you can see that the PT sort of, so I took another very steep angle. And here you can see, if you can look, the PT has a very, very, very tight lesion, but then you can see it kind of reconstitutes. And if you keep going down, that's the only vessel which is severely diseased right in the middle portion. Peroneal looks severely diseased and like islands. And going all the way down, that's the main vessel going to the foot.
Hey, Raja, it's Jaffer. How are you doing? So quick question. I think I missed the symptoms on the left leg. I know you said the right leg had critical limb ischemia and you fixed the right SFA. Did the patient have critical limb ischemia in the left leg as well?
Double, sir?
Not the wounds. It's kind of resting pain and some discoloration of the skin of the foot, like a toe area.
Got it.
And when you touch it, it's painful. So it's definitely ischemic. It's kind of waking him up at night. So yes, very symptomatic.
Thank you.
Very interesting.
Okay,
This
so
is an
what I
aberrant
did
takeoff.
is
Yeah, high takeoff of the PT,
Yeah, it's an aberrant
right at
takeoff.
the knee.
correct. So I'm going after PT. So I just want to, this is a new wire. I've just started using cross lead by Asahi. I've used a few times, and it's like a combination of Gladius and Command. It's a 3-gram hydrophilic, very nice tip, and I want to use and see in this tight lesions, how does it work? So that's where I am right now. So let's go down to here we go. So if we go back and see where was our lesion, it's around a 150 area. So I was LO 17. Let's go to LO 17. Okay. Okay, here's my catheter. So we're going to make a sort of a roadmap here to help me to do that. Okay, ready? Let's make it. Okay. Good. Okay. So I'm going to go with the wire. I want to see how it really works.
Magic.
Beautiful, huh? It's really, you can control one-to-one torqueability, and so, okay, so I'm gonna go further down here. I'll get my catheter down here. And actually, there was another lesion here, right? Distally. So let's make another roadmap here quickly. Here, do it. You want to do it from here? Okay, let's do it from here. Okay. So okay, you can see that, those areas. I just want to see how torqueability of this wire is. So that's one of the advantages of going integrate is that you won't lose your torqueability. Going up and over would have been a major headache to torque these wires because it just, okay, so it went very nicely. I'm just going to go all the way down now, and then I have a feeling IVUS may not cross, but let's try see if we can cross through the IVUS. Okay, give me 4,000 happen. Give me a puff here. No, it's okay.
This is an 014 wire, correct?
Yeah, this is an 014 wire. I think they also have a 018 wire, but I don't know if it's available or not. They said to me it's not available. Fred is sitting there. He can answer your question.
Laiq, how big is
this? I don't have to go this.
Yeah, how big is this guiding catheter, the support catheter that you're using? Is this an 035 support catheter?
No, 014. Everything is 014.
Okay.
Usually when I go to the tibials, I treat them like coronaries. And I use everything 014.
Okay.
So I don't want to hurt the vessel. Let's leave it here. Distally. Okay. So now the question is, shall we directly go with something to debulk, or shall we? So we can IVUS. I think it's going to be hard to get the IVUS. It's a pretty calcified area. But I like to see if.
Yeah, I think, you see that it's diffusely diseased, proximally in the mid-vessel. There's a heavy calcification there. So I'm not sure how much benefit you'll get from IVUS, and almost you may have some challenges, getting that down. And so my thought process is I would debulk that first. I would probably use orbital atherectomy, 1.25 micro crown. I like to use the undersized crown just to debulk. You kind of imagine there's like these stalactites and stalagmites in that artery, and all you're really trying to do is polish that and debulk that, and then follow it with a, 1-to-1 balloon angioplasty.
So then you're switching out for a different wire to do the atherectomy.
Mm-hmm.
So Jaffer,
the way I do it is like I get the wire down and I send an IVUS. If IVUS doesn't go, I go to CSI. Because you don't really know where this calcification is. Is it adventitial or it's interluminal area? So sometimes I'm being surprised that it looks very calcified, but when you go, inner plaque is not that hard, so then I use laser, as you're saying that, if I have to do PSI, then I have to really exchange the wire. So let's, hold on. Okay. So, yeah, I agree it's a lot of calcium, right? So it went smoothly. If iris goes, most of the time, the laser will go. But it's a 360 degree.
You're using a
Okay.
Phillips system, so
So-
if that goes, anything would go.
Yeah. So I like the orbital atherectomy.
No, because it's the
But I
profile.
always worried about distal embolization. Okay, record. So, if I have to, yeah, of course, I will. But if I can do something different, like in this case, iris went very nicely. I will do a laser rather than orbital. I mean, Y is already there. So let me have a 1.4 concentric laser. Whatever, rapid exchange is good.
So Dr. Walker, you're a master in laser atherectomy. So how efficient and efficacious is laser for calcium?
It's less, and there are two different lasers now presently available, and they have different effectiveness on calcium, for sure. So in the formation of a laser impulse, the first thing one gets is light. That is followed very closely by an acoustic shock wave, and one can harness that. Now, if available for this to me with medial calcium, I think this would be a lithoplasty.
Olivia, can you see the vessel diameter?
And so that I think would be a great option. Now in the Thor trial, they're using the laser with 308 nanometer laser and contrast within a contained space in an effort to create a lithoplasty-like effect. With the Orion laser, the 355 nanometer laser is modified. It starts off as a 1055. And then it's run through a series of prisms, basically, and it becomes 355. That's how they do that. They're subtracting out some light, and they're blending some back together. It tends to have a much bigger
Yeah.
acoustic shock wave, but
45.
with that, there's a bit greater
Jacob, look
risk
for
of destroying
253
the
or
end
210.
of the fiber optics. So anyway, either of those could work. But if you had every option here, I
going
would
backwards.
really like lithoplasty because it has no real risk of emboli that has been reported yet. This is medial calcium, and I think that might be a
And
great
and
option.
it's
Yeah,
it's
blood is
supposed to
going
be
backwards.
60.
I think though that to answer your question, the current shockwave, current lithoplasty is based on electric coupling.
Yes.
And those degrade with a certain number of pulses. That's why the catheters expire, you gotta throw them out. The next generation IVL devices, IVL balloons are being developed is with laser.
Yeah.
And so the science has been there for 15 years, and we know that laser works in this, and so now they're harnessing it in a balloon for the next generation IVL devices. So I think that it's gonna be a matter of time before we're using laser routinely through balloons to get the same effect.
Yeah, that is actually available. We
On-
just started with
Ready?
Boston Scientific seismic device.
Yeah.
That's the new
Yeah.
laser-based.
But it's a
liquid
similar
frequency.
type laser technology. That's been there. We've known that for 15 or more years, that it creates that sonic effect and it creates that calcium modifying effect.
Yeah, and the nice thing with the
210
Boston seismic catheter is you get double the amount of shocks. So you get 600 instead of 300 pulses. And the UI, user interface is really nice, so.
Yeah, that will be true for all laser-based. They're going to all have much, much longer shock. You probably could have yet more than that.
All right, gentlemen, we're asked to switch over. We're going to leave this case and jump to Dr. Ramaiah.
No. Back. Where's the wire?
Back
Yes, the wire.
at 1 p.m.
1 p.m.
All right. So we did iris, and it shows like a lot of calcium, and the vessel diameter is like 2.5 going distally, and then it gets to like 3.0 proximally. So I picked the Medtronic tapered balloon 2530210 and went all the way down till I don't know why Jorge pulled the wire, but okay. So now Jorge, pull this back and go all the
He's
way
in
up to the
outpatient
ostium
setting,
there.
so they just had reimbursement come through for that, right?
Yeah.
Yeah.
Okay, hold on here. Give me a puff here a little bit and see where the ostium is. Okay, here we go. Okay, let's go up here. So recently I've been utilizing this new technology. Dr. Craig Walker talked about it, this temporary stents, spur. Actually, we were part of their clinical trial, and the outcomes are very good. The main concept in the coronary, in the tibial is that, especially if they are calcified, is a recoil. You go up and looks pretty in 15 minutes, it's back to, so how do you stop this recoil? So the concept is this spur, which is implanted on a balloon, has small needles. You go there, you unsheath it, it comes out. You inflate the balloon, the needles get into the vessel walls, creating tiny, tiny dissections, like cracking eggshell. You leave it for 2 minutes and then come down. And their clinical trials have shown that significantly decrease in recoil. Actually, so good that they compared with stent, and there was no difference. So actually, this device has been approved as a stent, peripheral stent. But the good part is that you don't leave it. You inflate it, and then you take it back. So you can utilize it 2, 3, 4 times. And not that I'm saying it or asking you to do that, but you can get reimbursed 2 or 3 times for stents in appropriate settings and appropriate utilization. Okay.
I didn't know that.
Go back.
I would be very cautious about doing that from a billing standpoint, but, so we're running up.
Yeah. I'm with you. Okay. Okay, let's get
We're
some
running
micro
up
and
against
take
the
a
clock
picture.
here, so we should tie it up. We're getting ready for a lunch break, but thank you for some fantastic cases and wonderful teaching.
Absolutely. Let me show you the last
Yeah,
image.
let's look at the last image.
Yes.
What size of the balloon did you put in? What was the final size? 3.0 or 4.0?
2530 210 tapered balloon.
Oh, yeah, tapered. Okay, 2530. Small.
It's a tapered Medtronic balloon.
Yep.
Perfect for the peripherals.
Nice.
And you can see it all the way down. So most probably, I'm going to look for if there is any significant recoil. We may just do the proximal and some spur treatment.
Let's see the runoff.
Here you go.
Let's see the runoff here.
The runoff.
Oh, we missed it on the screen. Can you
So-
shift your image over? We couldn't quite see the vessel. There we go.
It's a PT runoff.
Yeah.
Should be fine.
So
For chronic.
I think today, and then I'm coming back, I'm going to fix the SFA. You saw it in the middle portion, but 70-80% lesion. And then see, hopefully, if its symptoms goes away, I will just leave it to that.
Wonderful case. Thank you so much.
Thank you very much.
Thank you so much. Hopefully to see you tonight at the dinner.